Welcome to this webinar of One Hand, 20 Surgeries. That's kind of a funny name for a presentation, but hang on a couple of slides and I'll tell you why that is. In this presentation, we'll look at hand anatomy in some degree of detail, conditions and injuries of the hand, and some CPT coding challenges, about 20 in fact. This presentation is worth 1.5 hours of CEU through AHIMA and AAPC. References I always have on hand, specifically your CPT manual, and I all but demand you have this on hand as you watch this presentation as we jump around the different body systems that the hand occupies so you can look over the codes. I'm also not fond of putting mountains of CPT codes on slides, and so this will allow you to sort of poke around at your own pace, pause the presentation, get a sense for the section of CPT you're in, and get a sense for it. CPT Assistant is occasionally referenced in this presentation, always valuable to have on hand, and some other references you'll see as well. The CEU credit from this presentation is earned through taking a post-test with a passing grade. You should be presented with that test immediately after viewing the presentation here, and it's worth 1.5 CEUs through AHIMA and AAPC. Different certificates, but those certificates will be issued immediately upon passing your test. You can download, print that out if you need it, or keep it handy. And the post-test information should be found along with the link where you found this presentation. The CEU credit earning is good until April 30th, 2019. My name is Ed O'Byrne, and I've been in medicine pretty much my whole life. I was first an EMT and then respiratory therapist, and then ended up 11 years as an emergency medicine PA. Saw tons of hand injuries and conditions, and was always fascinated by the hand. Ultimately, I ended up drifting into coding and documentation, and have been first a frontline coder, inpatient and outpatient, then a consultant and auditor for 10 years subsequent to that. And currently I'm the Director of Revenue Integrity, HIM Revenue Integrity, that's coding and documentation improvement for Healthcare Resource Group. My favorite quote about the hand, and really about human existence and cognition itself, really comes from one of my favorite authors and psychologist, Steven Pinker, who says, "Hands are the levers of influence on the world that make intelligence worth having." So really, a big brain like dolphins have is pointless if you don't have hands to do something with that intelligence and problem solving that we've got. Dexterous hands wouldn't be much good if we didn't have much of a brain. I mean, in fact, the apes have pretty dexterous hands, but they just don't do much but swing from trees and use rudimentary tools, and so you kind of need the both. So hands are incredibly vital to humans and to civilization as a group, as well as to each of us as individuals. And I think we take our hands kind of for granted. That's something like the back of your hand, because your hands just exist in the window of our daily life, and it's all you really see is your hands and entering that window that's the rest of the world is in. And they just do what you want, often without thinking about it much. Now, to do this, they have an incredibly complicated anatomy, and if you've coded any hand surgeries, coding them is the simple part. Operating on them is vastly more complicated. Now, this involves several different specialties too, so hopefully, even if you don't code hand surgeries, some of the principles that I illustrate in this presentation will translate into orthopedic surgery, plastic surgery, and especially integumentary like flaps. Vascular specialties too. There's, of course, a vascular supply to the hand, and that gets operated on from time to time. Now, most hand surgeons are super specialized or subspecialized. You may think of it as orthopedic surgeons or plastic surgeons, and the plastic hand surgeons can work on bones, and orthopedic hand surgeons can work on the skin too. That's just kind of where they meet up. One small caveat during this presentation is, because it involves a lot of surgeries, there will be some surgical and graphic injury images. I mean, nothing too extreme, but just know that that's coming up. The learning objectives, as I'm required to give to you by AAPC and AHIMA, you'll see below. I won't parrot those out to you, but we'll go over a kind of a variety of 20 and a couple of odds and ends procedures on the hands. Not exhaustive, but a really good cross-section of the things you're likely to encounter frequently, and even some kind of unusual ones that if you do encounter them, you'll be glad that you heard about them here first. Okay, here are the 20 surgeries that I will present during this webinar, and they did indeed all occur on one patient's hand over a span of about 2.5 years. That's kind of an arbitrary theme, but it's a great cross-section of lots of different procedures, some of them very common, tending towards the left-hand column and higher, and some pretty uncommon ones tending towards the right-hand column and down lower too. So I've elected to sort of slip you in the shallow end first, some of the easier to understand procedures first, and then we'll kind of gradually go deeper and deeper into the hand and further along in the complexity spectrum. This is an exhaustive list of hand surgeries at all. I really urge you to get your CPT manual out. So if I touch on a particular procedure, look at the procedures associated with it so you can help differentiate that. So when you see a real op report, you can make that distinction too. So how I'll go about this is we'll first look at the anatomy, the relevant anatomy, for example, the carpal tunnel, the median nerve, the transverse carpal ligament. Then I'll discuss the pathophysiology, the problem at hand or injury at hand, and then we'll look at the coding briefly. It's so usually 2 to 3 slides per condition that we'll see here, sometimes just one. Okay, let us start with the ubiquitous carpal tunnel syndrome. Most of us will have coded outpatient surgeries will encounter this, and unfortunately a lot of us coders will actually have had carpal tunnel syndrome because of the prolonged sort of typing and keystroking that we do. Now the symptoms of it are pain and numbness along the median nerve distribution. And the median nerve, it has a motor branch, but let's focus on the sensory branch for now, provides sensation to the palmar aspects of the thumb, the index finger, the long finger, and I say long instead of middle to distinguish it from the small finger. Hand surgeons like to say long and small, so little sounds like middle too much, and the ring finger. So here's you can see the illustration in the lower right of the slide there, and the purple is the sort of the business end of the median nerve distribution. Now there's some sensory component of the dorsum of the tips of the fingers. That's not crucial, but for grasping, the median nerve is your key nerve. And you can easily remember this by if you sort of make a fist in the British tea drinking with your pinky out, every part of your hand that's touching another part of your hand, which includes the palm of these 4 digits, the insides or the intertriginal spaces of each of those fingers is served by the median nerve. What's not served by the ulnar nerve is the ulnar aspect of your ring finger and all of the small finger. The radial nerve serves the sensory distribution of the dorsum of the hand. It's not that critical to the function of the hand, but that's depicted in the pink in the illustration in the lower right. So the carpal tunnel is the passageway through the volar aspect of the wrist for the median nerve and the flexor tendons of the fingers and of the wrist. And what forms the pulley over those tendons is the transverse carpal ligament. Now the pain and numbness is 1 from the physical pinching of the nerve and 2 from ischemia that occurs from the median nerve. Median nerve, just like all nervous tissue, is very metabolically hungry, and so by starving it of a little bit of oxygen, it tends to shout out and cause, the pain and numbness that we feel from it. So a carpal tunnel release is the treatment of choice for definitive treatment of choice for carpal tunnel syndrome if conservative measures don't work. And the goal is to release the transverse carpal ligament, which forms the pulley over the tendons. It just so happens the median nerve passes through that pulley and in the tunnel too, so it has to share that space. Often a small forearm fascial release is performed. So the forearm muscles have fascia, which is somewhat very analogous to the transverse carpal ligament in its substance, but it can also pinch the median nerve right about there. But be wary of coding a fasciotomy. I'll tell you a little story in a minute about forearm fasciotomies done with transverse carpal ligament releases. Now, a local neurolysis or neurolysis is included. That's to kind of free up the nerve around there if it's scarred in or adherent to the surrounding tissue, but an internal neurolysis or neurolysis is pretty rare, actually. That's going through the myelin sheath of the nerve itself and into the individual's fibers in the nerve. So that might warrant its own code, but a local external neurolysis is included in a carpal tunnel release. Done in 2 ways. The traditional way is an open carpal tunnel release, and a longitudinal incision is made directly over the transverse carpal ligament, which is here, right here, as little as you can get by with. And then it's just carefully, an instrument is placed underneath it to guard the nerve and the tendons, and a scalpel is used to just cut right through that. The CPT code for that is 64721. You can see where the surgeon has traced a pathway where they might need to make further incisions if they found some additional constriction of the median nerve. For example, the forearm fascia ends right about here, and if that was also pinching on the nerve, It might extend this excision and make a little nick right there. This open carpal tunnel release obviously demands a left or right, or heaven forbid, a 50 modifier if it's twice or both sides at the same time. And the story I was going to tell you about is I worked at a hospital that was frequented by surgeons from a very large hand surgery syndicate, I guess I should say, or franchise almost, that had this very tricky, sneaky, templated operative report that included I'm quoting from memory, there was a constriction noted at the distal forearm fascia, so 1 centimeter incision was made, thereby performing a forearm fasciotomy. Well, if you dig around in CPT, you'll find that a forearm fasciotomy code reimburses way better than the carpal tunnel release. So this was a fraudulent statement and just a total pitfall for coders who would just get suckered into coding that as well, and I bet they made millions of dollars for it. That syndicate is now out of business, and the proprietor is actually dead. So forgive my aside there. Now it's increasingly more common endoscopic carpal tunnel release too, and the principle is exactly the same. It's a release of the carpal tunnel through cutting through the transverse carpal ligament. Only a hook knife is used, and so first an endoscope is placed through a smaller incision, usually transverse, proximal to the tunnel, and then the hook knife instrument is placed distally through a small incision across just proximal to the long finger or the ring finger, and passed back until the camera can see that hook knife coming at it. It's hooked around the transverse carpal ligament and pulled back under direct visualization to make sure the nerve and the tendons aren't caught in there. And then code for that is 29848. It's very hard to miss the distinction between an open and an endoscopic. They're pretty straightforward for us coders. Sometimes you'll see it as a release of transverse carpal ligament and not a carpal tunnel release. It's all the same thing. It's just a small semantic twist. Then obviously a site modifier is needed for this code as well, right, left, or 50. Now, so you may wonder, how can you cut through this pulley? Doesn't that cause any problems? Well, if you think about our strongest grip for the hand is with the wrist neutral or an extension like this, which tends to preload the flexor tendons to the fingers and to the wrist. That is, it stretches them out so the muscles in the forearm can contract more forcibly. Try to grab something with your wrist like this. It's really weak. Neutral or extended, it's fine. So that the flexor tendons, they do bowstring out away from the wrist in a carpal tunnel release like this when flexing with the wrist inflection, but in neutral or extension, then the underlying carpus, the bones, the wrist bones, become the pulley on the other side. So they already have a pulley. So try grabbing something like this and then flex your wrist and just feel how it almost wants to fall out of your hand. That's how come we can cut through the transverse carpal ligament without much problem. Okay, let's look at tendons. Tons of tendons in the hands. I will tell you hopefully just the right amount about the hand tendons and not too much, because they're pretty intricate. Tendons, of course, attach muscles to bones, and therefore they affect movement at joints. The tendons are comprised mostly of collagen, and that collagen is deposited in a very orderly, fibrous manner, incredibly strong by tenocytes. Tenocytes are really, really slow growing. They consume very little oxygen and glucose. The actual concentration of tenocytes in the tendon is very little. There's just a few around. They're just kind of like maintenance men, just hanging out, waiting for a tear or some little inflammation to occur to lay down more collagen at that site. Therefore, tendons heal extremely slowly. They are nourished by just a very few arterioles and venules, usually from the muscle they arise from. There's also some cross linkages to tendons that provide the blood supply to it. The peritenon is the membrane around the tendon, and that's where most of that the oxygen transfer and CO2 release and the glucose and other nutrients occurs from the sheath around the tendon. So you'll commonly see surgeons meticulously repair the peritenon around the tendon itself to provide nutrition. So here are the tendons. If this was a slide you wanted to keep a handout of, or there are certainly better references you can sort of get online or from books. But I'll go through these paying attention to the function of the tendons and the abbreviation for the tendons. Hand surgeons are famous for using these abbreviations, and so if you code any hands, you need to know these sort of like the back of your hand. I did it again. So first we'll start with the flexor tendons, which is the most sort of obvious and intuitive to most of us function of the fingers and the wrist is to grab things, pull your fingers in, pull your wrist in. The flexor digitorum profundus are the tendons that go all the way to the tips, the distal phalanges of each of the digits in the thumb. Therefore, profundus, they're profound, they're long. That's how you can remember that. The flexor digitorum sublimis or superficialis are the shorter, and they attach to the intermediate or middle phalanx of each of the digits. 2. Sublimis, because they're under the limit of the digit. So the limit is the tip, they're sublimit, so they're shorter. Or superficialis, because they are in fact less deep than the profundus too. So you can think about that either way, and that the abbreviation is still FDS. So FDP, FDS. The extensor tendons, there are a few more of them. The extensor digitorum tendons are named by the digit that they go to. So the extensor digitorum indicis, extensor digitorum longus, and so forth. So these are driven by a common tendon which arises from right about here in a single muscle. So all your fingers extend. If the extensor mechanism is intact, all the fingers will extend, and then to selectively flex individual fingers, the flexor tendons come into play. There is a special case of the extensor pollicis longus and brevis, and that is of the thumb. And you can see these on the back of your thumb if you extend your thumb out. And then even more special, the extensor indicis proprius and digiti minimi. So there's to the extensor indicis proprius, that's your index finger, extensor digiti minimi to your little finger. These each have their own dedicated extensor tendon that comes from its own muscle, which extends those digits. And that's why it's easier to do this heavy metal sign, so you can have those two tendons extending, than it is to just extend your your long and your ring finger down, because you've got those dedicated EIP and EDM tendons for extension. And then you have the abductors of the thumb. These are the tendons that move the thumb out away from the hand. And there's a pollicis and longus, and those are seen in the anatomical snuff box right here. And whereas you move your thumb out, you can see them. The thumb extensors and abductors are two of them actually share a sheath and a location in this spot. I won't bore you too much with the details, but notice that the abductors and extensors of the thumb pass through this area of your thumb. So tendon-related structures, you'll see these kinds of things in operative reports. Some of them are relevant to us as coders. The first four that you see, the retinaculum through the Camper's chiasm, those are important for us to recognize in an op report because they have specific related CPT codes. They're either specifically in the code or they're used as landmarks to help make the distinction for a zone in the hand. The second group arise from tendons, and I just want you to have a peek at those, so if you see them in a op report, you'll know we're working on a tendon, but they don't really have any direct implication in the coding. So the retinaculum, like the transverse carpal ligament, is a pulley, okay, around a tendon that allows the tendon to make a bend in some fashion. Bursae are sacs of sort in the palm of the hand, and you have bursae throughout your body, but it's kind of like a nearly hollow Ziploc bag with just a little lubrication in it that the flexor tendons in the hand pass through. And there's an ulnar one, which is large, and a smaller radial side. There are retinacula technically in the fingers too. We call them pulleys, and collectively those pulleys in the fingers are called the flexor tendon sheath. More on that in a moment. And the Camper's chiasm is the location which the flexor digitorum profundus, where it ceases to become the deep tendon and becomes the only tendon past the second phalanx here in the finger. So it passes through the sublimis and goes out to the distal phalanx too. I'll show a picture of that in a minute. And that demarcates zone 1 from zone 2 in the hand. Promise I have pictures coming up. The vincula are cross attachments and through which the vascular supply to the tendons passes. The juncturae cross-link the extensors. And you'll see in this picture of the extensor mechanism that's got the common extensor digitorum tendon, which branches out into each of the individual finger extensors. Now these have cross linkages which allow for a little bit of sort of insurance. If some of the tendons are lacerated on the back of the hand, oftentimes there's a cross linkage which will still allow the digits to extend. Because for these two fingers, That's the only extensor tendon that we've got. So if you've ever cut the back of your hand and cut one of these tendons, there's a backup plan, so to speak. And then slips are side branches of tendons, which occur mostly in the fingers, where the tendon will split out into two and rejoin itself. So not to focus too much on that, but just know that those exist, and you'll see them in the real world in operative reports. So trigger finger release. Does it have anything to do with this? No. So get that out of your head. Trigger finger is a condition where a nodule or enlargement in the flexor tendon, either or both of the sublimis or profundus, occurs. The ring finger is a common one, but it can really occur in any, and in fact, it can occur in the thumb as well. And it causes the finger, I'll use my ring finger too, it gets kind of stuck down, and then it pops up when we extend the finger, and then it pops back down. So the triggering is really just sort of that click through as that nodule passes back and forth between the constriction. It can occur from an injury, it can occur from chronic tendinitis, it can just be kind of spontaneous, but it's pretty annoying. And so here are the tendon pulleys and collectively the tendon sheath of the finger. So we'll see this is a lateral view, but this is the palmar aspect. So the anterior aspect of the hand. Remember the anatomical man, the hand is facing forward. That's the anterior, but really try to use palm. Well, if you were dictating, use palmar. If you're reading it, just know palmar means this side. Sometimes volar is used for this, but that really usually refers more to the forearm. And then the dorsal for the entire forearm and hand. So we have palmar flexor tendons here, and here we're looking directly at the palmar aspect too. So see these pulleys are named A and C. A is annular, so those are round ring-like pulleys. And C is for cruciate for cross, and these are crossed pulleys. And they're just numbered from proximal to distal. There is an A1 pulley, I'll show you in just a moment, but in essence you've got the A1, 2, 3, 4, and 5. And then you got the cruciate C1, 2, and 3. Some of these are crucial to functioning of the flexion of the fingers, and they prohibit bowstringing of the flexor tendons out away from the bone, and some of them are kind of sacrificial. They're nice to have, but you don't really need them, and the A1 pulley is one such. So here is the A1 pulley here, and there's a ring-shaped pulley around the flexor tendons that it inserts at the metacarpal head. This is where finger triggering occurs, and this is the tendon sheath which is released during a trigger finger release. Then the bearing point of the flexor tendons becomes the proximal end of the A2 pulley, which is so close, very little, if any, noticeable function is lost in flexion. Now, if the A2 pulley is, let's say, injured or released inadvertently or on purpose, then the bearing point becomes the A3 pulley, and the C2 or C1 further down here, in which case the flexor tendons would bowstring over the MP joint, the metacarpal phalangeal joint, when the fingers were flexed like this. So that's a no-no. A1 releases what we want. The code for that is 26055 for the open trigger finger release. Now that code is not just for trigger fingers, it's for any tendon sheath incision for any purpose except for a drainage, 26020, which we'll look at in a sec. That includes the pulley, a pulley, multiple pulleys, or the sheath, depending on how the surgeon puts it. So all of those pulleys lined up in a row forms a sheath, and so that's how you commonly see it referred. But there's nothing wrong with the surgeon enumerating the pulleys one by one. Now pulleys in the finger get finger modifiers F1 through FA. In the hand, it's the laterality modifier. Now technically the A1 pulley is in the hand, as it inserts at the metacarpal. So that should technically require right or left. I, in my heart as a coder, if we've got a known digit from which it's released, would try to use the finger modifier, especially if there are multiples. If you have two trigger fingers, like a ring and a long, all you can do is use a finger modifier to distinguish that there were two. Okay. Now there is such a thing as an endoscopic trigger finger release, just like the carpal tunnel. However, there's not a code for it, at least as of 2018. So we have the unlisted arthroscopy code, which is a little weird, but that's what we use, 2999. Now onto the tendon sheath drainage. Okay, so same sheaths here. They're depicted on this illustration more as the sort of potential space that they are. They've omitted the actual individual pulleys and are now treating it as a hollow tube, which is a potential space for the likes of infection. Now there are tendon sheaths here. They're bursae proximally in the ulnar and radial aspects. And where it's drained determines the CPT code. So we have a drainage of the bursa, single or multiple, which is basically your ulnar or radial or both. So it's 26025 or 30, depending if it's both. Now, as far as the rest, we have the tendon sheath drainage, and that should essentially be used for any of these digital tendon sheaths drainage. Finger abscess drainage would be 26010 or 11 accordingly. Now, go with it. You have to take this case by case. It's hard for me to give a discrete slam dunk description for you too, because abscesses commonly involve, of several areas or several contiguous areas that you have to take into account. Here's what that might look like. The flexor tendon sheath of the index finger with an abscess. It causes this sausage-like fusiform, they call it. Like, it was actually like a skinny football or a cigar maybe. It's tapered at the end. It gets fatter and fatter and fatter. It's right here, and it gets red and real tender right there. And resisted flexion of that digit is painful. That's kind of the diagnostic pathway that we determine flexor tendonitis, specifically septic flexor tendonitis. Still with the tendons, let's look at tenolysis. So lysis is a release or a cutting apart. Tenolysis is performed for scarring and or adhesions of a tendon, either from chronic inflammation or an infection like the one we just drained. And that was the instance for the patient at hand. I did it again. Who had the 20 surgeries, had an infection, a drainage, and then a tenolysis. This is done a la carte per tendon. Now remember, there's two flexor tendons, so that a tenolysis in the flexor tendon sheath has got the two tendons at least proximal to the intermediate phalanx here. So if both of those are tenolysed, even in one digit, you will have two tenolysis codes for it. So we have a tenolysis code 26440 flexor in the hand or finger, and then we've got the entire course of that tendon in the flexor in the hand and finger, same tendon, like the FDP and the FDS. From the hand all the way into the finger, you'd use this code twice. And then we have the extensors, hand or finger, and extensor complex. And I would have to defer to the surgeon to designate what was complex, what was simple. We just kind of have to demand that in the procedure note. There's not any distinction in the CPT descriptor. A brief note on hand incisions too, particularly the distinction between a Z-plasty and a Brunner incision. So what we see here in both of these pictures is a Brunner incision. They are Z-shaped. These are not Z-plasties. Okay, there is such a thing as a Z-plasty on the hand, but for every one of those, there's 100 or more just plain old Brunner incisions, which are Z-shaped. So be careful not to code a Z-plasty when a Z-shaped incision is made. Now, the point of a Z-plasty of a Brunner incision is to avoid scar contracture. Linear incisions made over the fingers contract in a linear fashion. So a long incision scar shortens itself as it heals. So what's done instead is the incision is made from the flexor crease across diagonally to the flexor crease, across diagonally to the flexor crease, and back. And so that allows the scar to contract a bit lengthwise, but also it shares that contraction laterally too. So it's a more balanced contraction of the Z-shaped incision. It also allows the surgeon to pull back these flaps, this one to our left, this one to our right, to expose what's underneath, probably a flexor tendon surgery here. So better than a straight incision where they've got to get some aggressive retractors in there. You can just pull these flaps back. Here's a similar one done over the palm of the hand, Z-shaped, with the apex of the Z at the flexor crease. This one's at the sort of the terminus of this flexor crease. I don't know if that's a lifeline, love line, what the other one is, but here's the third one, the apex there. So 1, 2, 3, and off. So again, this is for scar contracture control, not a Z-plasty, Brunner incision. So a common excuse to make a Brunner's incision like that is, such as you see here, a tendon repair. In fact, this surgeon has made a Brunner's incision, the apices of the Z back and forth, back and forth. There's a couple of intermediate ones too. This is probably actually like a 4-point Brunner incision. And they hold back the flaps with usually sutures that are either held by an instrument or sometimes they just suture it right to the skin, right there and there. Afford me a digression here. If you ever read a lead hand in an operative report, you say, what the heck is that? It's actually a piece of this, like, this is roofing material, but it's lead, and it's this bendy stuff, and it's heavy, and it just stays in place, but it's cut out like the shape of a hand. So they'll put this under the hand and then fold the fingers of the lead hand over the fingers of the patient's hand to hold them all extended. Anyway, a little bit of trivia. So for us as coders to deal with a tendon repair, we need to know a few things first. First of all is the timing of the repair, primary or secondary. Primary is an acute injury. Secondary is a delayed injury, is the simplest way. Now, there's no clear-cut demarcation like at 14 days it flips from a primary to secondary. Make the surgeon designate that. Second, whether it's done with a graft or without. Flexor tendons are under a lot of tension, and the muscles, the flexor muscles in our forearms, tend to retract the tendons back into the hand, and with time even more so. So the need for a graft is ever present from day one, and it increases when we get into the secondary tendon repair, flexor tendon repair territory, because they need to often make up that space. And then finally, the type of tendon being worked on. So the extensor on the back and dorsum of the hand, that's the easiest for the surgeon, easiest for us to code. There's just one code. The next hardest is the flexor tendons in the hand, the sublimus and the profundus, FDP, FDS. And depending on what zone it's in, I get ahead of myself a little bit. And then finally, the type of the flexor digitorum profundus. That's the long tendon. So allow me to explain. So in zone 2, or not in zone 2 for the flexor tendons, zone 2 is seen here between the distal palmar crease and about the middle of the intermediate phalanx too. Your second phalanx, your middle bone, partway down right here. Okay, remember what happens there is where the profundus tendon comes out from underneath the sublimus tendon and extends all the way down to the distal phalanx. That's the camper's chiasm. That's a little window where tendon passes through tendon, and that happens here and here. At the proximal end of zone 2 is where the A1 pulley starts. So this is all flexor tendon sheath. So we call this no man's land because there's a lot of business going on in that, and it's really hard to do work in it, particularly if the tendon is retracted back into the hand. It needs to be pulled up into that sheath in no man's land and repaired. It also tends to scar worse. Digitorum profundus and sublimus scar to each other. They scar to the pulleys. They can scar to any adjacent fractures. It's kind of a mess. So surgeries in no man's land, zone 2, they're harder and they reimburse more. So not in zone 2 down here, not in a pulley, in the bursa possibly, but very easy to get into, low incidence of problems. So that's a lot of sweat off the surgeon's brow, whereas no man's land is a lot of sweating. And then the worst of all is the profundus distal to no man's land. The profundus will commonly retract all the way back into the hand or even sometimes the wrist. So that's why the flexor digitorum profundus gets its own special code outside of the otherwise flexor tendons in zone 1 or zone 2. So open your CPT book to this area and kind of poke around and you'll kind of see the distinctions there. So these are some of the codes that you'll see for these flexor tendon repairs. Now, I won't read those to you, but you can see them in your book and you see them on the slide there. The special case of the 26370, the flexor digitorum profundus with an intact superficialis, primary repair. That's pretty unusual to occur from a penetrating injury because the profundus overlies the sublimus tendon. The sublimus overlies the profundus. So to have an intact superficialis and somehow the flexor tendon beneath it is lacerated is pretty hard to do. Now, sometimes an avulsion will occur where the flexor digitorum profundus will pull off the distal phalanx and then down into the tendon sheath, and the sublimus is still just fine. So that's such an instance. But here's a little bit of a coding riddle. What if it's the profundus tendon, but it's in zone 2? There is a CPT assistant in 2008 that says use the zone 2 code for that case. It's a little bit confusing. I encourage you to look it up. I'm not satisfied with it as a coder really, or as a former physician assistant, but it's succinct and you can always point to it and say, that's my reference. I hate to give that kind of CPT assistant advice, but there it is. Okay, so tendon repair. Here's an example. Here's our patient at hand. This is kind of a crazy looking thing. You see the flexor tendon having been repaired and healed. translating back and forth beneath an opening in the skin. That opening was left open after a subsequent abscess drainage. Remember a few slides back, the flexor tendon sheath drainage? That's what happened. That's the only reason that's left open. This was a flexor digitorum profundus done with a local flexor digitorum sublimis graft, 26356, left hand. Both of these were ruptured by a fixation screw through the metacarpal and the phalanx, matter of fact, so that should give you a clue of some of the more procedures you have coming up, that were screwed all the way through the bone and into the tendons and gradually wore through the tendons so that they ruptured. So the surgeon used a little bit of sublimis tendon to bridge the gap in the flexor digitorum profundus tendon. So this is a one tendon finger. The tendon goes all the way to the end and provides flexion, but ended up working pretty well. Getting even a little bit more fancy with tendon transfers. Now, here I'll focus on functional tendon transfers that affect the kinetics, that is the actual movement of the fingers. There's a separate set of tendon transfers for the intrinsic function of the hand, which is sort of the static neutral position of the hand. These are for like claw finger and claw hand abnormalities that just change the sort of neutral position of the hand into one that's more pleasing and functional. But for the purposes of our patient, we have tendon transfers that affect how the fingers move. The codes depend on the location, so of a dorsal or CMC, the proximal palm, whether with a graft or without a graft, and palmar. Here's an example of extensor endosus pollicis to extensor pollicis longus. And so this would be a patient. This is not our patient we're talking about, but it illustrates the point well. The patient has lost the ability to extend and abduct the thumb. So the thumb would just be kind of floating in this position, which is useful because it's opposed and can be pinched to, but cannot be gotten out of the way to put the hand flat or to get the thing in the hand in the first place. So the extensor endosus proprius of the index finger, remember the index finger's got two extensors, it can spare to lose one. Transfer one of those over to the thumb, so now the thumb can be extended. So the EIP extensor endosus proprius has been cut loose from the index finger and will be tunneled over to the base of the thumb proximal phalanx. Our patient had this exact same procedure except flexor tendons of the index to the thumb to provide flexion of the thumb, which was lost, instead of extension. So just like this, but opposite side of the hand. Now, the intrinsic muscles can trip up a lot of clinicians and coders alike. I still do not have an intuitive sense for the intrinsic muscles, but let's think of them collectively because the code actually treats them sort of anonymously and collectively, so that's fortunate for us. There are several different names and they have several different functions. The key takeaway of the intrinsic muscle anatomically is they're fully inside the hand. So they're intrinsic, they're in the hand. The extrinsic muscles, which articulate the flexor and extensor tendons, are located outside the hand in the forearm. So they're extrinsic, outside the hand. The main names of the intrinsic muscles are the lumbricals and interossei between the metacarpals, here and here. And then we have these special cases of the abductor digiti minimi and the abductor pollicis brevis and longus, which are what fan out your index finger and your thumb, respectively. You can do that independently. I can really not do it with my little finger. And then the opponens, this is an important one. This opposes and adducts your thumb. So it pulls your thumb in and it crosses your thumb. Some simplistic definitions of what makes us different from animals is the opposable thumb. Some animals have opposable thumbs, yada yada. It's not real, but nevertheless, it's incredibly important function to be able to oppose your thumb like that, since then you have something to pinch too, whereas if a thumb that just hangs out here isn't much good. So your thenar eminence, this big chunk of muscle right here, is the opponens intrinsic muscle. The lumbricals and insert from the flexor digitorum profundus to the extensors distally. They start on the flexor tendon and end up on the extensor tendon. It's weird, right? The interossei are similar, but they originate from a bone and they insert on the extensor tendons. So what they help do is sort of, you've got your flexor, your brute force flexors and extensors. We covered those a few back. What about the fine motions between your fingers like this and placing them down or making these fine little adjustments between? watch a pianist's hands in action in slow motion, and you'll see this is what's happening with those. But what can go wrong with an intrinsic muscle contracture is you can get a swan neck deformity is one example of that. Here we have the intrinsic muscles originating from the metacarpal and the flexor tendons extending around the sides of the finger and inserting on the extensor tendon. So these are tendons that are meant to, again, finely move your fingers back and forth from one another for placement. What it tends to do is pull the metacarpal phalangeal joint in flexion, but the extensor tendon is still working, and that pulls everything else in extension. So this is meant to represent the head, neck, and body-ish of a swan, and that's called a swan neck deformity. So 26393 is the CPT code for release intrinsic muscle hand each. Each muscle, piece of cake, right? So this would probably involve releasing 2 muscles. And I found most hand surgeons are pretty good about designating that's the case. And I'm not sure what the MUE is for this code. It's probably 10 or quite high, unlikely to exhaust, because there are many intrinsic muscles that can be released, and not uncommonly all at once if you've got a swan neck deformity or claw deformity in all of the fingers. Hey, here's a blast from the past. It tells my age. Remember this guy? Remember this brief period when we get off Marine One and, wave at us, little kids, on TV, and his finger was like this? That's a Depuytren's contracture. And that's probably second only to the carpal tunnel syndrome, to sort of bread and butter stuff that hand surgeons will see. Depuytren's contracture is a scarring of the palmar band of the hand, which is this part right here, and originates from the palmaris longus tendon. And it's just sort of an accessory tendon sheath-like thing that helps us sort of bring all the fingers in the palm together in flexion like that. It's not crucial. Some people don't even have a palmaris longus tendon. But when that flat fascia-like band can tend to contract and scar in certain places, it pulls the finger down with it. It's more common in Northern Europeans. Some people call it Viking's disease. You'll know that if you're on Jeopardy and that gets called out. Thin habitus, like Ronnie, predisposes to you. Smokers, I don't know, he probably smoked in his acting days or something. I don't know. He's supposedly Irish, but that's probably more trivia than you wanted to know. Ring finger is more common. Here you see a nice illustration of it just scarred and pinched down and pulled together, but really annoying, so you can't get those fingers flat. Easily treated, though. Now, there are non-invasive versions of this, ultrasound and heat therapy, and then there's the next more invasive is needle injection of certain lytic agents. Then there is the fasciotomy, which is just cutting through, making a hole, otomy, in that fascia. And it can be done percutaneously with a needle, with a literal needle, or with a special sort of a very thin scalpel, but through a small incision through the hand. Not this, okay, hold on. And then you got the fasciotomy open, partial, and it's never done completely, because then you're getting into fasciectomy, cutting some of that substance of that fascia out. Well, we've got the sort of the ordinary version in the palm only, fasciectomy for Depuytren's contracture. And then we've got the palm plus the finger, which this patient who has had, mind you, a Brunner incision down into the finger released. Now, not to confuse you further, but this fasciectomy includes grafting and Z-plasty if done. This hand is not a Z-plasty, because you can see the apices of the incision are at the palmar creases, and there's no rearrangement of tissue. A Z-plasty involves taking and switching the apices of the Z to provide prolongation. So this one isn't that, but it can be done, and if it is done, it's included in that fasciectomy code. Okay, now we'll go back out superficial and do some skin stuff. Now these skin debridement procedures are not hand specific like wound repairs are. There are some muscle and fascia debridement codes, but they're not likely on the hand because, as you see, there are not many muscles in the hand, and the fascia-like substances, like the palmar fascia, just discussed in the Depuytren's contracture, and the transverse carpal ligament and pulleys are all sort of fascia-like. They have their own codes too. So fascia debridements codes not likely in the hand. So in a nutshell here, your debridement codes in the hand, you have your skin and subcutaneous excisional debridement, ever important to all in and outpatient coders, by the size and by the code, each additional. The selective wound care or non-excisional debridement without using cutting mechanisms, scraping, pulse jet, and so forth. We have the same size indications here. Debridement of a fracture, skin and subcu, and then down including the bone. These are common in the hand, actually. And then a burn and debridement, less than 5% body surface area is all you'll ever see on the hand, because it just doesn't occupy, even both hands, the entire hands, both of them together do not equal 5% body surface area. Now, after having done such a debridement like that on the hand, skin coverage on the hand is, you could argue, probably more important than skin coverage anywhere, because it has such intricate movements, and the skin has to extend and contract and be flexible in certain ways to allow the hand to do those things. So scars are bad for hands. So split thickness skin graft is one way to cover those wounds. If you've ever wondered why they mesh these split thickness skin grafts, well, to start with, why is it split thickness? You can shear a sheep many times, slaughter only once. By cutting the skin only part way through on the thigh or the buttock, for example, you can harvest that spot again, and it also heals quicker. So you've got a thinner graft to start with, which actually heals quicker on the recipient site. The meshing part does several things. It takes a small harvested piece of skin and allows it to be expanded many times sometimes. It also increases the surface area of the graft here, in and around the holes, the underside, the top side, and so forth. So by increasing the surface area, it increases the ability of the tissue there to imbibe or soak up nutrition and oxygen from the wound underneath. Because remember, there's no blood supply to this graft right now. It can only survive by just sucking up nutrients by being in proximity to living tissue. And as sort of a secondary benefit of meshing is it allows drainage of wound fluid and blood from underneath there to the outside world. If it was not meshed, it could sort of blister and bubble up and sort of separate the graft from the tissue underneath, and then it would immediately die. So you have to have a way for egress of the fluid and blood underneath. Split thickness skin graft is pretty straightforward. It's not hand dependent, of course. 15120 is for less than 100 centimeters squared, which is just about all you'll ever see. There's just not that much room on a hand. There's not much more than 100 centimeters squared. Now, mind you, it is the recipient site dimensions. My harvest might be 20 square centimeters, but after meshing, it could be 40 square centimeters to cover a large portion of, say, the back of the hand. That's the site of the dimensions, but again, I'd be surprised if you saw it surpass that, unless it was maybe the hand and the wrist. Remember the prep codes for receiving the skin graft, such as 15004. I kind of think of that as, this is not just to pick the blood and clot out of their stuff. This is a dedicated, focused removal of eschar and dead tissue to present a healthy, viable wound bed to receive that skin graft too. There are also several other skin grafts that you'll find, the epidermal, dermal, full thickness, nowadays cultured xenograft synthetics in the range of 15040 to 15278. You can look those up, and there'll be, I'm sure, more weird stuff coming up, auto cultured from yourself stuff, pretty cool stuff. Now, local skin flaps. So this is not split thickness. This is leaving a piece of skin, usually in the hand, not with any subcutaneous tissue, just the dermis and the epidermis, but still remaining attached to its origin site at a pedicle or a stalk, so to speak. And this allows the flap to preserve its vascular supply. It's a generic vascular supply, I say, because it doesn't involve a named vessel. You just take whatever arterioles in that area, and these are usually pretty small in the hand, as you can imagine, and that allows that flap to live as it heals. The size of the skin flap is designated by the donor plus the recipient dimensions too. The description is the primary defect resulting from the excision and the secondary defect resulting from the flap design to perform the reconstruction are measured together to determine the code. That's your sort of CPT descriptor to fall back on. So here we see on the lower right an illustration of an advancement flap, where this is your defect. Maybe you could say that's 1 by 1 centimeters. And then this flap is incised and undermined, and maybe say that's 2 centimeters squared and is pulled forward and then sutured in place here. So we rearranged that tissue, and it's local because it's still attached here. A rotation flap, our defect is here. That's not likely, a triangle defect would occur, but probably an excision or a puncture wound, gunshot wound, something that then becomes converted to a wedge shape. And then this amount of tissue is liberated, undermined, and then swung around in place and sutured in place. So our local skin flap dimensions is this whole thing. And then a transposition flap is much like the advancement, except instead of just stretching out linearly, it's excised and it's swung over. And this is an example of a Z-plasty as a transposition flap. Swung from here to here. The dimensions are this rectangle plus this rectangle for our coding purposes. And there's what the end result kind of looks like. So your code choice is 14040 for less than 10 centimeters, which honestly is what you're usually going to see in the hand. But there are larger ones, and they're still larger than 30 centimeters squared, but you're never going to see that in the hand. There's a special case of a filleted finger flap that will be described thusly and will be easy to code. Don't be scared. Quick digression, here's a procedure that our patient did not have, but I will mention it because I can easily imagine a coder scratching their head and wondering if this is the right one. Cross finger flap. It's exactly what it sounds like if you step back and look at it. It's from one finger to another finger. So a patient who's had, for example, their distal finger amputated off, usually accidentally. You see the digital nerve here. This is just a little spacer to illustrate it. That's not left in there, just to show us that it's there and what we're trying to cover up. A small wedge of skin is excised in a crescent from the adjacent finger, but not completely. It's left attached right here. And it's swung over and covers up the distal finger here. And then after several weeks, once this is healed in place, this is delayed or cut off right there. And the two fingers become independent again. Seems kind of weird, but it works quite well. This is not a local flap because the skin didn't come from here to here. It wasn't transposed, advanced, or rotated from that same finger to itself. It comes from somewhere else, but it's left with a pedicle. There are other examples outside the hand, outside the purview of this presentation, but pedicle flaps are pretty cool. So cross finger flap 15574, should you ever see one of those. Now down to the bones. Quick lesson on these. These would be the palm of your right hand if you held that out and looked at it right now to understand the 27 bones in the hand. It's another good trivia question. The distal phalanges or phalanx, the intermediate, or you'll hear them sometimes the second phalanx, or even the middle phalanx, and that also helps to kind of not conflict with the long and small finger. You have a middle in there. But intermediate is really the ultimately preferred term. The proximal phalanges or phalanx, that's the universal term for that. The metacarpals and the carpals. Note that the thumb does not have an intermediate phalanx. Okay, to code fractures in the hand and fingers, sort of the formula is to know the bone or joint and the approach. And they get pretty detailed here too. So first we'll start with a percutaneous pin fixation or K-wire fixation. K-wire is a Kirschner wire, named after presumably the surgeon who developed this. And it's a pretty cool, minimally invasive procedure that involves using this sort of chisel-tipped wire that acts as a drill and can be just drilled right into the bone. In this case, it's being used as a sort of a joystick. You'll see that in op reports a lot of times. Drilled in, and then it reduces the fracture, and then it's drilled in the rest of the way, right down there. Now, because this provides only one axis of fixation, it prevents bending back and forth, but doesn't prohibit rotation. Usually you'll see two pins inserted. So that holds this fracture right here, and it looks like the thumb proximal phalanx from rotating against itself, shortening, lengthening, or deviating back and forth. And these are almost uniformly removed after 4 to 6 weeks after the fracture is mostly healed. Metacarpal fractures, such as you see this second metacarpal fracture, really notorious for rotating, and it's a real no-no to have fingers end up crossing each other like that in flexion. They could look fine in extension, but when they flex, they cross, and that's a bummer. So that's why really careful fixation, often with K-wires, of a metacarpal fractures is important. So to code these is fairly straightforward. with finger modifiers, distal phalanx, other phalanx, so intermediate or proximal, and then the metacarpal. Piece of cake, right? Now for dislocations, you've got down to the joint. These are often reduced and pinned in place while the surrounding ligaments heal. Now that's all percutaneous with the K-wire. We've got closed with or without manipulation, which could include the first instance of applying the cast and the global period after that for all the care of that closed, no manipulation. But there are reductions of finger fractures and hand fractures, closed, and then on to open. And because of all the dynamic and static forces in the hand, open fracture repair is apples to apples more common in the hand probably than most areas in the body. And also the precision of getting it back together right is arguably more important in the hand. So open fracture treatment, it's almost always done with some fracture fixation apparatus like these plates, but it doesn't matter for the code. You just, all open is coded as just open treatment of the fracture. Can be a plate like you see here. These very thin titanium or stainless steel plates, which can be easily bent. They're not that strong. They really hold the bone together. They do not impart any strength to the final construct once it's healed. We can use the K-wires, cerclage wires to be wrapped around the bone. These are all included in the same code, so don't fixate too much on, dumb pun, fixate too much on the fixation hardware as to whether it influences the code or not. And this is down to the same again, distal phalanx, other phalanx, which is what the patient had, the intermediate and the proximal phalanges both, and metacarpal had some of those in fact too. And then whether a dislocation of the carpal metacarpal joint, the metacarpal phalangeal or interphalangeal joint. So the carpal metacarpal joint is between the carpus and the metacarpals here. The metacarpal phalangeal are your knuckles, your punching knuckles right here. And the interphalangeal joints are here, the proximal and the distal interphalangeal joints. So when things go wrong in a joint through arthritis, injury, or infection, sometimes the cartilage can be lost, and the nice gliding function of the joint needs to be replaced by some means. Now, there are arthroplasties done with implants, artificial implants. This patient didn't have that. What he had was an intercarpal or carpal metacarpal interpositional arthroplasty with a tendon or ligament, otherwise referred to as an LRTI or ligament reconstruction tendon interposition. And here we see the ever common arthritis at the first carpal metacarpal joint, or the basal joint at the thumb, because remember the thumb moves around in so many directions and gets so much use through our lives. That's a primary point for arthritis to form. You can see a nice cartilage joint space between these carpal metacarpal joints here, metacarpal phalangeal joints, but it's just obliterated here. Bone spurs, very small space. So the interpositional arthroplasty is meant to restore something in that joint space upon which these bones can glide against each other with little or to no friction. What's commonly used for this interposition or putting in between is the flexor carpi radialis or other local tendon, which can be gotten by without. In other words, the patient can still function without it. They'll cut that tendon loose, stuff it in here, and the tendon transfer itself is also coded as 26480. That's the carpal metacarpal area or the dorsum of the hand. So if the flexor carpi radialis here is harvested, that's your tendon transfer. And then the interpositional arthroplasty itself is the stuffing in of that little, they call it an anchovy a lot of times, into the joint space here. There is a coding clinic for HCPCS, refers to the transfer of tendon if you ever need to back your case up for using 26480. There you have it. Also a trapezium excision of this bone, sort of shadow behind here, is included in this interpositional arthroplasty code. The interpositional arthroplasty of the carpal metacarpal joint of the thumb, the basal joint, is actually what our patient ended up with in the end, and is also by far the most common interpositional arthroplasty in the hand, which is why I wanted to show you that one first. To hold off from blowing your mind yet, I'll make sense of this in a minute. What the patient actually had initially was an interpositional arthroplasty at the metacarpophalangeal joint, here of the index finger. It all makes sense in a second. This is less commonly done, and it's done with local ligaments, to some sort of expendable ligaments in the adjacent area, commonly the palmar plates, which is the ligament here on the palmar, the palm side of the joint, which helps to prevent the finger from overextending, gets excised here or here and then stuffed into the joint, and therefore it becomes a cartilage-like substance over which the bones can slide to. So you're less likely to see this. The ultimate intention is exactly the same. The donor tissue is different, but it's pretty straightforward to code. Now, don't confuse these with an arthroplasty with a prosthetic implant, which is, frankly, these days more common than what you're looking at here. That's not what the patient had, but you're more likely to see it. There's a separate and very obvious code for the prosthetic implant code, and that's for the metacarpophalangeal joints. Rheumatoid arthritis is a usual time that you'll see that kind of thing done. Then if the joint is unsalvageable, arthrodesis can be performed. 26820 through 26863 depends on the joint, is what it comes down to. And with finger modifiers, you can tell the full story in your CPT coding. Arthrodesis is not unique to the hand. It's any case where a joint is either irretrievably damaged by infection or trauma or hemophilia, used to be in the day. And arthrodesis may be the treatment of hand. In the case of our patient, it was a post-infectious arthritis in a joint that just completely wrecked the cartilage, the ends of the bones, the surrounding tissue. It was just never going to be reconstructed. In this case, it was an interphalangeal joint, but there are dedicated codes for the carpal metacarpal joint, metacarpophalangeal joint, and interphalangeal joints, both proximal and distal. This is done with or without autograft. And there's a special case for the thumb being fused in opposition. So you choose your code with or without autograft. All of the K-wires and plates are included, and it's a pretty neat, concise set of codes. It's not easy to get confused. The thumb opposition case done at the carpal metacarpal joint, the same one we just reconstructed. If that's not an option, or if that was an arthroplasty was done and it failed, sometimes the thumb will be just fused in the most functional place where the fingers can come down to meet it, but it doesn't move. But that's a last resort. You'll see that in among the codes if you have your manual. Nerve repair is a little bit of a weird detour out of our usual pathway of orthopedic type stuff, but this patient required some nerve repairs, and the best one can do as a surgeon, these nerves are all very small, is align as best as possible using surface landmarks like the vessels around the nerve to get it aligned rotationally so that hopefully the nerve fibers will be roughly approximated, then using extremely fine sutures like 8 or 9/0, which are some of the smallest they've got, just to suture the nerve sheath around and then let it grow back together. Now, it has to occur through myelinization. It's not like just soldering wires back together. That nerve has got to remyelinate, or essentially rebuild the insulation from proximal to distal along the entire length. And that takes about 1 millimeter per day. So it can take weeks, months, years, even for the nerve to refunction. And then it's never quite the same, but better than nothing. If there's a gap in the nerve, a nerve conduit can be used and allow the nerve fibers to grow across and remyelinate. They'll never match up perfectly, but again, some functional sensation, protective sensation, and motor function can occur. That nerve conduit can be synthetic, or it can be a local vein or a cadaver vein that's processed specifically for that purpose. So nerve repairs, we have the suture of the digital nerve, 64831, and these are the digital nerves, digit as in finger. That's pretty straightforward. You have the ulnar on this side of each digit, because here's the ulna, and then the radial digital nerve on the radial side of each of these fingers here. Those are all digital nerves. The hand common sensory nerve, these are the common nerves that serve multiple sensory digital nerves, and including the radial nerve is a common sensory nerve in the hand too. That's not shown on this picture, but is a common sensory nerve in the hand. Then you've got the special case of the median motor and the ulnar motor nerves. Motor nerves are more critical to repair because the intrinsic function of the hand to oppose the thumb and adduct the little finger, a little less important, but opposing the thumb, that is crucial. So a median motor thenar repair, 64835, has its dedicated code. And then we have your additional add-on codes for digital in the finger and add-on of hand in the hand, add-on codes there. Now, arterial bypass, taking it even further off the usual hand surgery radar, but this patient did need a arterial bypass. And I like to kind of geek out on this because it's one of the more remarkable designs of the hand for having collateral circulation. So if you look at this depiction of the arteries in the palm of the hand, this is like a vertical mirror image of your right hand. So here's the radius and ulna, and we have accordingly the radial artery and the ulnar artery, which arise from the brachial artery further up in the forearm. From that, we have a deep palmar arch here, and more importantly for the purposes of discussion, the superficial palmar arch, in which these two arteries anastomose together. One of the few other places in the body this occurs is the circle of Willis in your noggin, and this provides a backup plan if there's an injury or occlusion, for example, of the superficial palmar arch here. The blood from the radial artery can find its way around to the digital arteries here. If the occlusion is here, it can find its way from the ulnar artery to the same place. So it's collateral, it's backup in case there's an injury. Unfortunately, the patient had injuries to both the radial and ulnar arteries, so there was nothing getting to the fingers at all. So the arterial bypass at hand is from the ulnar artery to the superficial palmar arch. It happened to be right at the base of the ring finger, so this ulnar artery was teed into the distal palmar arch with the means of a venous graft obtained from the forearm to bridge the gap that was there. So, in the menu of CPT choices, we have a gazillion different arterial bypass choices. I have carefully read this and found nothing to do with ulnar artery to hand or really anything remotely that distal in the upper extremity too. So in this case, we would be compelled as coders to use the unlisted 37799. And amputation, this is not uncommon, involves multiple body systems from skin, subcutaneous, nerve, vessel, bone. Okay, almost by definition, cross-section through the finger. The two types of amputation, both clinically and for coding purposes, are of the digit or of the ray. A digit amputation is what you kind of think of as just a finger or thumb. A ray amputation is excision of the digit as well as the metacarpal that it arises from. There's a variety of reasons. A simple one to understand would be like a long finger amputation would leave this big gap in the finger when the hand is closed, through which things could fall, like holding coins in your hand or keys and that kind of thing. So it's not uncommon to remove the entire ray, the metacarpal and the digit, and then just close everything together. So it's just a narrower hand, but works just well. So that's a digit versus ray. The codes for which are 26910 through the metacarpal, through the phalanx 26951, and if flaps are used to close, for example, this wound, 26952. So flaps will be used from more proximal on the digit and advanced out to cover this up. Now, a couple of things. This patient this hand tells a story. You can see this is a hardworking guy. His hands are dirty. He's got calluses from grabbing things. It's a right hand, probably dominant, statistically speaking. He's got stuff under his nails too, and probably chop that off in a power tool or a press or something like that. I had a physician once who was a preceptor of mine at the VA, and he would always try to determine a patient's VA. They're almost all men, profession just by looking at their hands, and could do it with remarkable accuracy, probably 75% of the time. But I digress a little bit. The other point I was going to make is what's the difference between a bony debridement and closure versus an amputation? And when I worked in the ER, I did a lot of procedures that kind of rode that line too. My best advice for you as a coder is the takeaway message is to demand and that for your to code an amputation through the phalanx, that the operator, whether ER physician or hand surgeon, use the word amputation, or completion amputation is what you'll likely see with an injury like this. And therefore you can code amputation versus a bony debridement. and skin closure and so forth. Now, pollicization, bet you never heard of this. Okay, pollex is the Latin for thumb, and so to pollicize is to make something into a thumb. And there are two discrete codes, and you'll never miss it. If you see the op report, you won't mistake it for anything else, and you can find the codes easily. 26550 if another digit is made into the thumb. 26551 if it's a toe made into a thumb. And this is most commonly done for patients who have a congenitally absent thumb, or a hypofunctioning thumb, or a floating thumb that is missing the metacarpal and is otherwise sort of undeveloped and just doesn't do anything, particularly the ever important opposition like this. A severe trauma to the thumb can require pollicization. I challenge you to tape your thumb up against your hand for an hour and go about your day with just fingers. It's pretty tricky. And how this works is, take a patient here who's congenitally born without a thumb. The index finger metacarpal is transected here, and that distal metacarpal is bolted into the carpal, like the trapezium, right here, rotated, and if the tendons are intact, they're left, but they're not always developed. But they try to leave them if they can, and the blood vessels are left intact, the nerves are left intact. So here was where the index finger was, here's what the index finger is, and here's how that hand works with an opposing thumb. It's very handy stuff. Opponent's plasty also pertains to that ever important opposition of the thumb. And there's several different kinds of this. Now this is usually performed on a thumb that's a native thumb that's just lost its function. And the whole idea is to find something to pull the thumb across the palm like that. Now, since most of the flexor and extensor tendons pull this way, you can't just hook it to the thumb. It would just pull it off in a weird direction. Something has to be done to make it pull diagonally like this. Superficialis flexor tendon can be wrapped around an adjacent structure and then across to the thumb. And the patient just has to kind of remap cognitively so that instead of flexing a finger, they pull their thumb across. Other flexor tendons can be used. The hypothenar muscle here can be used and released and then cross over to the thumb. There are other methods that you'll see under 26496. And again, the whole purpose is to restore opposability of the thumb. The patient that we're talking about had a palmaris longus tendon to graft to the original flexor tendon of the thumb, but at an angle, so it provided opposition of the thumb instead of just straight flexion like that. The palmaris longus, by the way, most people have this, I don't, can be illustrated by touching your thumb and little finger together, thumb and small finger, I did it, and then flexing your wrist, and that tendon that pops out there is your palmaris longus. It's present in, I think, 85% of people. Then it's just a common source of graft to be removed since it's not critical and be used for another procedure somewhere else. Well, that is the conclusion of my One Hand 20 surgeries. This has been Ed O'Byrne with Healthcare Resource Group, and if you've stuck with me this long, it's probably I owe it to you to reveal that the patient I've been presenting is myself, and there is my post-20 surgeries over 2.5 years hand after an injury when I was about 31, playing with pyrotechnics. I'll just leave it at that. So hopefully I will see you out in the field or on another webinar, and if you care to see my injury, I have a slide following this which is pretty graphic, but I think illustrates well the miracle of modern surgery and persistence on part of a team of people that helped me and patients on my own, and it turned out well enough that it works. I'm happy for that. So take care of yourself and take care of your hand.